Today, we are taking, I think, the ultimate shortcut into the pharmacology of power.
That's a good way to put it.
We're doing a real deep dive into the world of androgens, the male sex hormones, and then the synthetic steroids that come from them, and of course, those revolutionary treatments for erectile dysfunction.
And this isn't just a list of medications. It's really an exploration of biochemical control. The sources you shared, they map out this incredibly complex system, and they show us that when it comes to male hormones, the body is often relying on these conversion products and specific enzymes much more than the primary hormone itself.
Exactly. And that's our mission today. We want to move way beyond just the surface definitions. We want to understand those intricate feedback loops.
Right.
Like specifically, why is an estrogen the most potent brake in the entire male hormonal system? It's fascinating.
It's completely counterintuitive.
It is. And we want to know why a tiny difference in where an enzyme is located dictates whether a drug is going to treat hair loss or, say, an enlarged prostate. And, of course, we have to dissect the surprising and often life-threatening risks with some of the most popular drugs on the planet.
Well, to frame this a bit, I mean, historically, the effects of androgens, these are substances that cause the development of male characteristics in someone who's been castrated, that's been observed since, well, antiquity.
Right, for millennia.
But the modern understanding is surprisingly young. It wasn't until 1935 that the core hormone, testosterone, was actually isolated, its structure figured out, and then synthesized in a lab.
And that milestone, the synthesis, that really just unlocked everything for the pharmaceutical industry, didn't it? The ability to start manipulating these pathways.
Absolutely. And based on how they work, the sources really break these compounds into 5 main groups. You've got your natural and synthetic androgens, of course.
Okay.
Then the often misused anabolic steroids.
A huge topic.
Then the various anti-androgens, which are designed to block the hormone's effects. And then the really targeted stuff, the 5-alpha reductase inhibitors.
The enzyme blockers.
Exactly. And then finally, those vascular game changers, the drugs for erectile dysfunction.
Okay, let's unpack all of this. And I think we have to start right at the source.
No.
How the body makes and uses its primary male hormone, testosterone.
Let's do it. Let's start with natural production and the basic chemistry. The primary engine of production in adult males, that's in the testes, specifically in these cells called Leydig cells.
The Leydig cells, right. And they're just pumping out testosterone constantly.
Constantly. They produce it at a rate that varies a bit, but it's usually between 5 and 12 milligrams every single day.
And the precursor, the basic building block for every single one of these steroid hormones, is something that most of us are trying to get rid of, right?
That's right. It's cholesterol. All steroid hormones, testosterone included, they begin their life as cholesterol. The body just takes that molecule and, through a whole series of enzymatic steps, converts it into the final product.
So testosterone is made, it circulates. But then we immediately hit this really crucial point of complexity. Testosterone itself isn't always the active agent.
Correct. That's a key takeaway. Testosterone often serves as the circulating prohormone.
A prohormone.
Yes, a precursor. A significant and, frankly, essential step happens in various target tissues, so outside the testes, where an enzyme, steroid 5-alpha reductase, converts testosterone into dihydrotestosterone, DHT.
So DHT is like T's superpowered cousin.
Precisely. In a lot of key tissues, DHT is the version of the hormone that actually gets the job done. It's the more active, the more potent metabolite.
Okay, so besides the testes, are there any other, contributors to this whole androgen pool?
Yes, the sources mention what they call weak androgens, specifically dihydroepiandrosterone and androstenedione.
Okay.
These are made in small amounts by the adrenal cortex, and in their original form, they're basically inactive.
So they don't do much on their own?
Not really. They only get their weak potency. We're talking maybe 1/20th to 1/30th the activity of testosterone, because they get partially converted into testosterone in peripheral tissues. Think of them as backup generators, not the main power plant.
Right. And just to round this out for our listener, we should probably mention testosterone in women.
Oh, absolutely. It's certainly present and it's essential, but at much, much lower levels. The ovary and the adrenal cortex produce it, typically somewhere between 1.25 milligram per day.
Which is a tiny fraction of the male production rate.
A tiny fraction.
Yeah.
But it's still absolutely necessary for mood, libido, and bone health in women.
Okay, now we get to what I think is the most interesting part, the regulation. And this surprising role of estrogens. When we think of hormonal balance, we usually think of a simple thermostat. Level gets too high, you shut off the furnace. What are the official signals that control those Leydig cells? It's called the hypothalamic pituitary gonadal axis. That's the thermostat. The primary signal comes from the pituitary gland, and it's a hormone called luteinizing hormone, or LH.
LH.
LH pulses travel through the blood, they hit the Leydig cells, and they stimulate them to secrete testosterone. Separately, another hormone, follicle-stimulating hormone, FSH, that controls spermatogenesis, the actual making of sperm.
So if testosterone levels rise, that testosterone should signal back to the pituitary and say, hey, shut off your LH up. That completes the loop. How good is testosterone at sending that stop signal?
That's the fascinating thing. Testosterone itself is actually a pretty weak inhibitor of LH secretion. I mean, yes, very high concentrations of T will eventually inhibit LH, but the primary mechanism for potent real-time feedback control, it involves a completely different hormone.
And this is where it gets really interesting, because the body has this incredibly complex way of signaling that it has enough T, and that signal is estradiol, an estrogen. I just want to pause here because that nuance is just mind-blowing.
It is the absolute core insight into male hormonal regulation. Estradiol, which is generated from the conversion of testosterone via an enzyme called aromatase in tissues like the liver and fat. That estradiol is a significantly more potent inhibitor of gonadotropin secretion, that's LH and FSH, than testosterone is.
So the body doesn't just measure T, it measures the downstream product, the estradiol, to confirm that it's saturated. It's the T being converted to E that really slams the brakes on the pituitary.
That is the most accurate way to put it. If that conversion didn't happen, the negative feedback loop would be far, far less sensitive. This small amount of estradiol acts on both the pituitary and the hypothalamus to powerfully inhibit the release of those signals telling the testes to make more T.
Which is just so counterintuitive for most people. We associate estrogens purely with female physiology. Is there anything else that contributes to this feedback system?
Yes. There's also a protein called inhibin. It's produced by the Sertoli cells, the ones involved in sperm production. And inhibin is highly specific. It puts a very strong inhibitory brake on FSH secretion, which kind of completes that dual hormone feedback from the testes back to the brain.
All right, let's move on to the actions of testosterone. I mean, these are the visible physical changes we all associate with male development.
You really have to separate them into two groups, the androgenic effects and the anabolic effects. The androgenic ones are all about creating the male phenotype. This includes all the major pubertal changes, the growth of the genitals, penis, scrotum, seminal vesicles, prostate.
We're talking about all the secondary characteristics, right? The features that distinguish men from women after puberty.
Exactly. This is what drives the male pattern of hair growth. The beard, pubic hair, underarm hair, and sometimes later in life, male pattern baldness. It also causes the skin to thicken and get greasier because of the sebaceous glands, which is the direct mechanism behind teenage acne. The larynx grows, the voice deepens.
And what about the less visible changes, the internal and behavioral ones?
Well, testosterone is definitely associated with increased physical vigor and energy. And, certain behavioral changes, sometimes including increased aggressiveness. It's also absolutely crucial for libido. Although some sources suggest that the estradiol derived from T might play an even bigger role in centrally activating male sexual desire in the brain.
So even libido might be an estrogen effect. That's wild. Okay, now for the anabolic effects. This is what everyone thinks of when they hear the word steroids. Muscle growth.
Anabolism just means building up. Testosterone promotes muscle building, which increases body weight. But that weight gain isn't just muscle. It's also the accretion of nitrogen, essential minerals like sodium, potassium, calcium, and water. It often improves appetite and just a general sense of well-being.
Now, here's a key detail that I think is often missed by people who misuse these compounds. Who actually benefits the most from that muscle building effect?
The sources are very clear on this. Exogenous androgens, so steroids you take externally, they show a far more marked muscle building effect in women, in children, and in men with hypogonadism, so low T.
More so than in healthy adult men.
Much more so. The marginal gain is far, far greater when you're starting from a low baseline.
That makes perfect sense. I mean, the receptor saturation point is probably already close to max in a healthy adult male.
Indeed.
Let's talk about bone growth. The bone growth mechanism. Puberty involves that huge, rapid growth spurt, but then eventually the bone plates fuse and you stop growing. This also hinges on that conversion process, doesn't it?
It's another brilliant example of T acting as a prohormone. Testosterone causes the initial rapid increase in linear bone growth and thickness. But, and this is the key, it is the estradiol produced from testosterone through that aromatase enzyme that is ultimately responsible for the fusion of the epiphyses.
The growth plates.
The growth plates, yes. That's what stops linear growth, and this happens in both sexes.
So T slams the accelerator down, but at the same time, it starts producing the very hormone that's going to eventually pull the handbrake. If you didn't have that aromatase enzyme, I guess you might just keep growing, but your bones would be weaker.
It's exactly right. Estradiol also largely mediates testosterone's long-term effect on bone mineralization and maintenance. It just proves its essential structural role, not just a regulatory one.
And finally, the effect on blood cell production, on erythropoiesis.
Testosterone accelerates red blood cell production. It does this by increasing the output of erythropoietin. That's the hormone that signals the bone marrow to make more red blood cells. And this is the physiological reason why males, on average, have a higher hematocrit, a higher proportion of red blood cells than females.
Okay, so we know that T is the circulating hormone. Let's look at the molecular switch, how it actually gets inside a cell and tells it what to do. This takes us right back to T versus DHT.
The key, again, is that T is a prohormone, a precursor. In most of the target cells that are sensitive to androgens, so think prostate cells, hair follicles, external genitalia, T is actively converted inside the cell.
By that 5-alpha reductase enzyme.
By that enzyme into the more potent form, DHT.
So why does the cell even bother with the conversion? What's the point?
It all comes down to binding strength and activity. DHT binds much more avidly, more tightly and more efficiently to the cytoplasmic androgen receptor, the AR. And on top of that, the resulting DHT receptor complex is just better at interacting with the cell's DNA to modify protein synthesis, which is the ultimate goal of the hormone.
So T gets you in the door, but DHT is the one that actually sits down at the control panel.
That is a perfect analogy. But the sophistication doesn't even end there. We have to talk about the fact that 5-alpha reductase isn't one enzyme, it's two. And this distinction is absolutely crucial for how the drugs are developed.
This is a major insight from the sources. So let's break down these two main isoforms.
Okay, first we have type 2 5-alpha reductase. This one is predominant in the male urogenital tract, so the prostate, genital skin. And critically, it is highly sensitive to inhibition.
Which is why the drugs work so well.
It's exactly why. And the sources emphasize just how important it is by noting that a genetic deficiency in type 2 causes something called male pseudohermaphroditism, where the body just can't masculinize the external genitalia even with normal circulating T.
So type 2 is the masculinizing and prostate-growing enzyme. What about type 1?
Type 1 has a much wider, more systemic distribution. You find it in non-genital skin, in the liver. It's also less sensitive to inhibition by the common drugs we're going to talk about. Its functions are less tied to sexual development and more to general metabolism and skin health.
So the body uses DHT for most of the big androgenic effects, but you said there are exceptions where T itself is the star player.
Yes, there are some vital exceptions where testosterone is the active hormone, no conversion needed. These include the fetal genital rudiments very early in development, the erythropoietic cells making red blood cells, the actual sperm-producing cells inside the testes, and that crucial feedback site in the brain.
That is a great example of cellular autonomy. The cell itself decides which version of the key it needs. Okay, let's get into the practical side. Overcoming pharmacokinetic challenges. When T was synthesized in 1935, getting it into the body so it would actually stay active was a huge problem.
A huge problem. It's twofold, really. First, natural testosterone is essentially inactive if you take it orally.
You can't put it in a pill.
Right. When you swallow it, almost all of it is destroyed by what's called first-pass metabolism in the liver before it even gets a chance to circulate. And second, its half-life in the blood is only 10 to 20 minutes.
So simple injections would mean you'd need multiple shots a day, which is not practical.
Not at all. So the challenge was, how do you either bypass the liver or slow down the release?
What were the first solutions they came up with?
Well, the earliest solution was creating oral alternatives, but they came with a massive risk profile. They modified the T molecule by adding something called an alkyl group at the 17th position.
Okay.
That created these 17 alkyl substituted derivatives, like methyltestosterone. And that modification lets the molecule resist that liver metabolism so it becomes orally active.
But what's the trade-off for that convenience?
A big one. The trade-off is significant liver toxicity. These compounds are known to cause something called reversible cholestatic jaundice, where bile flow from the liver slows down. And on top of that, they often have submaximal efficacy compared to other methods.
So if the oral drugs are toxic, what became the preferred method for decades?
That would be the second and more conventional solution, long-acting injectables. This method completely bypasses the liver's first pass.
How does it work?
They take these lipid-soluble esters of testosterone like enanthate or cypionate and dissolve them in an oily vehicle. When you inject that deep into a muscle, The compound is released very slowly over time, and the ester is gradually cleaved off to release the free, active testosterone.
And that slow drip mechanism must solve that short half-life problem.
It does. It allows for sustained blood levels, so you only need an injection every 2 to 4 weeks. For a long time, this is the preferred route for hormone replacement therapy.
And now, the truly modern solution, what's become the gold standard today, is transdermal delivery.
This is by far the most refined solution. Gels, patches, solutions that you apply to the skin. They allow the hormone to be absorbed directly into the systemic circulation,
Completely avoiding the liver.
completely avoiding the liver's first pass destruction. And crucially, transdermal delivery produces the most uniform, steady blood levels throughout the day, which often translates to better symptom management for hypogonadism.
All right, let's pivot to anabolic steroids. These were created with, I guess, a noble intention to isolate the muscle-building benefits and get rid of the virilizing side effects.
That was the goal, yes. Synthetic compounds like nandrolone or stanozolol were developed specifically to maximize the anabolic effect and minimize the androgenic effect. They were aiming for a cleaner therapeutic profile.
And how did researchers even try to quantify that separation?
They established what's called the anabolic to androgenic ratio. This was determined in castrated rats by comparing the weight increase of the levator anamol, that's the anabolic marker, against the weight increase of the ventral prostate, the androgenic marker. Testosterone was set as the baseline, 1:1.
So a ratio of, say, 3-to-1 would suggest a pretty big therapeutic advantage. But what was the reality when they tested these synthetic compounds?
Well, the sources reveal this critical gap between the intention and the reality. The selectivity they achieved was, at best, modest.
Really?
Yeah, these compounds typically only reached a ratio of 1:3 in rat models. It's probably even lower in humans. And since they still work through the exact same androgen receptor, the expert conclusion is inescapable.
That they're basically just androgens.
For all clinical and practical purposes, they're just androgens.
Yeah.
You simply cannot decouple the effects when they're mediated by the very same receptor.
And that failed attempt to separate the effects means that anabolic steroids share the entire adverse effect profile of high-dose testosterone, plus some of their own unique dangers.
Absolutely. The risks are substantial. In women, the most traumatic risk is virilization hirsutism, menstrual irregularities, and critically, a potentially permanent deepening of the voice if it's used for too long.
And for both sexes.
Acne is highly common. In men who are using them for performance enhancement, the constant high level of external hormones suppresses the body's own GnRH secretion, and that leads inevitably to testicular atrophy.
The testes shrink.
They shrink, and sperm production just grinds to a halt.
Let's spend some serious time on the specific dangers that are tied to those chemical modifications. The oral compounds, the 17-alkyl substituted ones, they're notorious for liver damage.
This is a major public health concern, especially for recreational users. Oral compounds like oxymethylone and stanozolol can produce this dose-dependent, reversible cholestatic jaundice. And more frighteningly, long-term, continuous use of these 17-alpha-alkylated oral steroids is associated with a significantly higher incidence of hepatic carcinoma.
Liver cancer.
Liver cancer.
And the cardiovascular impact is just as worrying, isn't it? It affects two critical cholesterol markers.
Yes. The 17-alpha-alkylated analogs, they're particularly known to negatively shift your lipid profile. They cause a distinct lowering of HDL, the protective good cholesterol, and a corresponding rise in LDL, the bad cholesterol.
And that directly increases your risk of heart disease.
It's a pro-atherogenic shift that directly increases the risk of heart disease, stroke, and early vascular damage.
So, given all these potentially deadly side effects, what are the contraindications? Where should these drugs absolutely never be used?
They are strictly contraindicated in anyone with carcinoma of the prostate or the male breast. Also inappropriate for patients with severe liver or kidney disease. And because of the risk of masculinizing a female fetus, they are absolutely contraindicated in pregnancy.
And what about older men?
Great caution is advised for older males, especially over 65, or anyone with pre-existing coronary artery disease or congestive heart failure.
Okay, let's look at the approved and controversial uses of these androgens and anabolics. I guess the most straightforward one is just replacement therapy.
For testicular failure or hypogonadism, replacement therapy using either the long-acting injections or the transdermal delivery is essential and highly effective. It restores muscle mass, energy, bone density, libido. It even corrects the myelonemia that's associated with T deficiency.
What about using anabolic steroids to treat general illness, what the sources call catabolic states?
In conditions like severe trauma or major burns, where the body's rapidly breaking down protein, anabolic steroids can temporarily reduce that nitrogen loss and improve appetite. They can provide a psychological boost. But, and this is a big but controlled, long-term studies have shown that the benefit for total sustained weight gain is questionable. Their utility is primarily short-term.
This brings us to a fascinating pharmacological paradox: idiopathic male infertility. Why is it so self-defeating to treat a low sperm count by giving the patient more male hormone?
It's a classic case of the body's own control system sabotaging the treatment. Spermatogenesis making sperm. It requires a hyper-concentrated level of testosterone inside the testes.
Right, locally.
Locally, when you administer external androgens, they suppress the pituitary's GnRH secretion through that feedback loop we talked about.
And that cuts off the LH signal.
It cuts off the LH signal, which causes those high local testosterone levels inside the testes to just plummet.
So you're giving a dose that helps the body systemically, but it shuts off the local concentrated dose that the testes actually need to function.
Exactly. The therapy undermines the physiological requirement. And the meta-analyses of clinical trials have concluded that oral androgens have no objective effect on sperm count, motility, or pregnancy rates.
Wow. And finally, the use related to aging and muscle wasting.
Well, androgens are certainly helpful in cachexia, or muscle wasting, seen in conditions like AIDS, as long as the patient has documented low T levels. They're also sometimes prescribed for elderly males experiencing age-related decline.
But the safety is a big question mark.
A huge one. We have to reiterate this point. The long-term safety of using androgens to treat age-related decline in otherwise healthy older men, especially regarding cardiovascular and prostate complications, is not established. The risks are significant, and the benefits in this group are still very much being debated.
Okay, we've spent half this deep dive talking about adding hormones. Let's completely reverse course and look at the pharmacology of androgen blockade. This is crucial for treating things like cancer, hair loss, and benign prostate enlargement.
Right. When we want to block androgen action, we have three main strategies. We can use GnRH agonists, which shut down the source most powerfully. We can use androgen receptor antagonists, which basically block the lock.
Okay.
Or we can use those 5-alpha reductase inhibitors, which prevent T from becoming that super potent DHT.
Let's start with the drugs that physically block the receptor, androgen receptor antagonists.
The oldest example in the sources is cyperterone acetate. It's a relatively weak antagonist chemically related to progesterone.
So it has a dual mechanism.
It does. It blocks the AR,
Sure.
and it also inhibits LH release because of its progestational activity, which helps reduce T production. It's used for things like precocious puberty in boys or hirsutism and acne in women. But its use is really limited by hepatotoxicity, liver damage.
Then we get to the nonsteroidal antagonists, flutamide and bicalutamide, which are mostly used in metastatic prostate cancer. And flutamide introduces that amazing concept we talked about, the flutamide paradox.
This is one of the clearest examples of the body fighting back against a drug. When you use flutamide by itself, it successfully blocks the androgen receptor in the prostate. Great.
Right, mission accomplished.
But because that prostate receptor is now blocked, the negative feedback signal that tells the pituitary to stop sending LH is also blocked. The pituitary interprets this as low T and just releases a surge of LH.
Oh, wow. So by blocking the receptors, you trick the brain into thinking T is too low, and the brain compensates by flooding the system with more T, which then tries to overcome the block you just created. That's completely counterproductive.
Exactly. Plasma testosterone levels increase substantially. And this is what limits flutamide's effectiveness as a monotherapy.
Huh.
To get around this, clinicians have to use it in what's called combined androgen blockade, or CAB.
And how does CIB solve that paradox?
You combine the AR antagonist, like flutamide, with a drug that suppresses the pituitary, usually a GnRH agonist or sometimes surgical castration. The GnRH agonist shuts down T production from the testes entirely, and the antagonist is then just used to mop up the residual androgens that are still produced by the adrenal glands.
I remember you mentioned there's a really subtle but critical timing detail when you start this therapy.
Yes, this is crucial. GnRH agonists, when you first give them, cause a temporary increase, a flare-up in LH and testosterone before they fully suppress the pituitary.
Which would be terrible for a cancer patient.
It would fuel the cancer. So to prevent that, the AR antagonist, flutamide or bicalutamide, is started 3 days before the GnRH agonist. That ensures the receptor is already locked down before that temporary hormonal surge happens.
Of those two, which one is preferred now?
Bicalutamide is generally preferred. It's more potent, has a much better half-life of about 6 days, and it's associated with less hepatotoxicity.
Now we come to those highly targeted enzyme blockers. the 5-alpha reductase inhibitors. And this takes us right back to the two isoforms.
The first major drug in this category is finasteride. It's a competitive inhibitor that is remarkably selective for the type 2 5-alpha reductase isoenzyme.
The one in the prostate and genital tract.
The very one. By targeting type 2, it significantly lowers the DHT concentration in the prostate and in the circulation.
And since testosterone itself mediates the LH feedback, finasteride doesn't trigger that flutamide paradox, right?
Correct. Because the drug targets the conversion process downstream of the feedback loop, plasma LH and total T levels stay relatively unchanged. It's a much more precise surgical block of just DHT synthesis.
How does finasteride specifically help with benign hypertrophy of the prostate, or BHP?
Well, BHP is that non-cancerous enlargement of the prostate, which is driven almost entirely by DHT. By reducing DHT, finasteride causes the prostate gland to actually shrink, sometimes by 20% or more, which improves urinary flow and symptoms.
That takes time to work.
It does. Because shrinking a gland is a slow process, the maximum relief typically requires about 6 months of continuous therapy.
And it often works alongside another type of drug for the best effect.
Yes, finasteride reduces the static component of the obstruction, the physical size of the gland. And it's often combined with alpha blockers, which relax the smooth muscles around the prostate, reducing the dynamic component.
And what's the connection to male pattern baldness?
Well, finasteride, at a lower dose, is also effective for treating male pattern baldness. It promotes new hair growth and prevents further loss. But similar to the BHP treatment, the response is slow. It takes at least 3 months. And the huge caveat is that the benefits reverse within a year of stopping the medication.
You have to keep taking it.
You do. We also have dutasteride, which is a newer inhibitor. Its big distinction is that it inhibits both type 1 and type 2 5-alpha reductase. It has a very, very long duration of action. Its half-life is around 9 weeks.
Wow. And what is the major clinical significance of this whole class of drugs when it comes to prostate cancer prevention?
This is a massive finding from large clinical trials. Both finasteride and dutasteride have been shown to reduce the risk of men developing carcinoma of the prostate by up to 25%.
That's huge.
It is. It means they're not just treating symptoms of hypertrophy, they're offering significant chemoprevention.
Okay, let's shift gears entirely now and discuss the treatment of erectile dysfunction. This category seems to rely less on hormones and much more on sophisticated vascular chemistry.
That's right. Let's quickly review the physiology of erection. ED is defined simply as the consistent inability to attain or maintain a rigidity sufficient for intercourse, and its prevalence really increases sharply past middle age.
And the process is all about blood flow.
It's entirely dependent on blood flow and smooth muscle relaxation.
What actually starts that relaxation process?
Sexual arousal. It triggers the release of key neurotransmitters. The main chemical responsible for relaxing the smooth muscle in the corpus cavernosum is nitric oxide, or NO. It's released from both special nerves and from the endothelial lining of the blood vessels.
So what does nitric oxide do when it's released?
It relaxes the smooth muscle in the blood vessels and the cavernous tissue itself, and this relaxation allows the blood vessels to dilate rapidly, leading to this massive blood filling of the sinusoids within the penis, which is what results in tumescence and rigidity.
What role do androgens actually play in this mechanism?
Surprisingly, androgen deficiency is an infrequent cause of ED. The vast majority of cases have underlying vascular or neurogenic roots. So testosterone therapy is only effective if the ED is directly linked to a confirmed, measurable hormone deficiency.
It won't help most men with ED from things like high blood pressure or diabetes.
Exactly. Which brings us to the PDE5 inhibitors, the first-line therapy that just revolutionized treatment. And the mechanism is all about preserving a temporary signal.
Okay, break that down.
The process starts with NO generating a secondary messenger inside the smooth muscle cells. It's called cGMP.
cGMP.
Right. Think of cGMP as the relaxation command. It's the molecule that directly tells the smooth muscle to soften and let the blood flow in.
And the body, being efficient, must have a built-in cleanup crew for that command.
Precisely. That cleanup crew is the enzyme phosphodiesterase 5, or PDE5. Its whole job is to rapidly degrade cGMP, making sure the erection is temporary and reversible once stimulation stops. By inhibiting PDE5, we stop the cleanup crew from working, which lets cGMP accumulate and powerfully potentiates the action of nitric oxide.
And sildenafil, introduced in 1998, was the pioneer. What made it such a game changer?
Sildenafil is orally active and highly selective for PDE5. And it's crucial to note, it enhances the natural response to NO. It requires sexual arousal to work.
It doesn't cause spontaneous erections.
Not at all. It only improves tumescence when the NO system is already activated and has a relatively short half-life of about 4 hours.
And the efficacy is incredibly high, isn't it? Even in challenging patient groups.
It's effective in a huge percentage of men, 74 to 82%, including those with significant underlying conditions like diabetic neuropathy. And we should also note its use beyond ED. Sildenafil is now a standard treatment for pulmonary arterial hypertension, or PAH, where it lowers dangerous pressure in the lungs.
Okay, now we have to spend serious time on the most critical safety warning. This is its interaction with nitrates.
This is a non-negotiable, life-threatening contraindication. Both sildenafil, the PDE5 inhibitor, and nitrates like nitroglycerin for chest pain are extremely powerful vasodilators.
They both widen blood vessels.
Massively. And when you take them together, sildenafil markedly potentiates the nitrate's action, causing a catastrophic, uncontrolled, and rapid fall in blood pressure.
A precipitous drop like that carries the risk of not enough blood flow to the heart, leading to a heart attack.
Absolutely. And since many men with ED also have underlying cardiovascular disease and might be taking nitrates, the sources are emphatic. Sildenafil is strictly contraindicated with nitrates, and because of the half-life, users have to avoid taking nitrates for a full 24 hours after a dose. This is a critical public health message.
There's also that odd visual side effect.
That's a fascinating chemical nuance.
Mm-hmm.
Sildenafil, while it's selective for PDE5, weakly inhibits another enzyme, PDE6, which is found in the photoreceptor cells of the retina. And that inhibition can cause a temporary minor impairment of color vision, specifically trouble distinguishing between blue and green.
Let's talk about tadalafil, which is often called the weekend pill because of its duration.
Tadalafil is a newer drug in the class that's more potent and, most notably, significantly longer acting. Its half-life is around 18 hours, which gives it an effective duration of action lasting between 24 and 36 hours.
Which dramatically changes the safety window for nitrates.
It extends the danger zone significantly. Because of tadalafil's prolonged presence in the system, nitrates are contraindicated for up to 3 days, 72 hours after a dose. The long half-life just demands immense patient caution.
Does tadalafil share the same side effect profile?
It has a lower affinity for PDE6, so those visual disturbances are less common. It's also approved for PAH. Its unique side effect, though, is reported back pain, which clinicians think is due to some mild inhibition of a different enzyme, PDE2.
So what does this all mean? We started with the physical effects of testosterone. We've ended up realizing that modern pharmacology is so much more nuanced than just flooding the system with hormones.
Much more.
We learned that the body relies on these conversion products like estradiol for feedback and DHT for activation. And we saw that the most successful treatments like finasteride and sildenafil, they target these very specific enzyme roadblocks, 5-alpha reductase or PDE5, instead of just overwhelming the system.
If we connect this to the bigger picture, the sources provide this powerful lesson in metabolic engineering. Managing these powerful hormonal effects, whether it's growing muscle, shrinking a prostate, or achieving an erection, it is entirely about leveraging these tiny, specific metabolic pathways and secondary messengers.
Right.
The fact that it's DHT, not T, that causes prostate growth, and that it's estradiol, not T, that fuses bones, it just demonstrates the incredible complexity beneath the surface that these drugs so skillfully exploit.
The journey from isolating testosterone in 1935 to developing drugs that block a single enzyme isoform or prevent the destruction of a tiny secondary messenger. It just illustrates this leap in precision medicine that has profoundly affected millions of lives.
Indeed. The difference between success and failure in treatment often comes down to knowing the exact cellular location and function of one enzyme versus another.
Which brings us to a final provocative thought for you to explore on your own. The source notes the widespread misuse of sildenafil by men without diagnosed ED, and this is blurring the line between medical therapy and lifestyle enhancement.
So, given the potentially fatal, non-negotiable contraindication with nitrates and that extended risk window with the long-acting versions, this raises a really potent question about public health communication. How successfully can risk information about a prescription drug be managed and conveyed when that drug is widely adopted for non-medical reasons, completely outside of direct medical oversight?
It forces us to acknowledge that the effectiveness of the drug often outpaces the public's understanding of its inherent dangers.
Absolutely. Thank you for joining us for this deep dive.
Until next time.